Briefly, by way of introduction, difficulty swallowing, otherwise known as dysphagia, is not a new topic. We're all familiar with it. Then we'll go through all these while addressing difficulty swallowing. It's likely going to occur at any age, but more in the elderly. It might be nothing serious. Maybe someone is just eating too fast or eating something too big than what he or she could swallow, or he or she has not chewed well before attempting to swallow. If it is not persistent, if it's just occasional occurrence, we will not bother so much. But this presentation will then become necessary when swallowing difficulty, either liquid or solid or both, is becoming persistent. And sometimes it might even be an acute emergency when swallowing difficulty is associated with breathing difficulty. If the person could no longer breathe perfectly anymore, call 911 immediately. Or if the individual is saying there's a sensation of food stuck in the throat or in the chest, just call 911 immediately. So it might be from nothing at all to something not so scary to life-threatening condition. Difficulty swallowing. Let's now go into full lecture mode on dysphagia. Hi everyone, thanks for listening to my presentations. Today I'll be talking about difficulty swallowing. That is a common or familiar topic, right? And the medical term here is dysphagia. I'll go over all possible causes, symptoms, diagnosis and differential diagnosis, and of course end it with possible treatment. Okay, sit back. Let's go together. Okay, like I said, not globus hystericus. Someone will ask, how do you mean? Globus hystericus is just a sensation of fullness in the upper esophagus. It is not associated with swallowing per se. For example, someone is having globus hystericus saying, I feel that I have fullness along my throat, but he grabs a cup of coffee and gulps it. That is not dysphagia. That is not swallowing difficulty. Or another one is saying, oh, I have pain while swallowing. That is Odynophagia, not dysphagia. Painful swallowing, you can still get the food down. The only problem is while swallowing the liquid or the solid food particles, you feel the pain. So the definition is clearer right now that it is not globus hystericus, it is not Odynophagia. Okay, so if it's not globus, if it's not Odynophagia, what is it? It is dysphagia, meaning a subjective sensation of difficulty swallowing. Like I've explained, Odynophagia to be pain while swallowing. Dysphagia could be sudden or gradual. Dysphagia, that is difficulty swallowing, could be to solids only or liquids only, or both. It could be initially difficulty swallowing solids, but now you are having difficulty swallowing both liquids and solids. Or it could be difficulty swallowing only liquids, not two solids. Okay, dysphagia could be acute in onset, and if that is the case, if it's so sudden, then please rule out foreign body in esophagus. Rule out possible food impaction. And we could further classify dysphagia as either oropharyngeal, that is, the problem is with upper esophageal sphincter, or as esophageal problem called esophageal dysphagia. The problem is within the esophagus itself, or as esophagogastric, which means the problem is at the level of lower esophageal sphincter between the esophagus and the stomach. We'll go into details of that in the course of this presentation. It could be para-esophageal, and I'll talk extensively about that in a bit, which means the problem is not within the esophagus itself, it is extrinsic. That will lead us to what could have happened to the lungs in lung cancer, what could have happened to liver adenopathy in the mediastinum, what could have happened to the heart vessels, like left atrial enlargement, left ventricular hypertrophy, or we are dealing with dysphagia aortica, massive aneurysm of thoracic aorta, and so on. Just continue following me. Okay, oropharyngeal dysphagia. At this level, the problem is you can't initiate swallowing. You can't even start it. And the affected individual will be complaining about coughing, choking, nasopharyngeal regurgitation, aspiration, sensation of residual food in the pharynx. So the individual had appetite, bought the food, bought what to drink with it, ready to now eat, but getting the food in the mouth, you can't even take it beyond that level down. You can't initiate swallowing. What are the possible causes of oropharyngeal dysphagia? Multiple sclerosis, amyotrophic lateral sclerosis, muscular dystrophy, myopathy, myasthenia gravis. You can check my channel for multiple sclerosis and myasthenia gravis. I have separate presentations for them. Parkinson disease, stroke. You can also check my channel for that. And of course, upper esophageal sphincter failure. Now, esophageal dysphagia. At this level, you were able to initiate swallowing, so it's not oropharyngeal. But you are having difficulty swallowing seconds after initiating swallowing. So there will be sensation of food getting stuck in the throat. And there's likelihood of problem with solids, liquids, or both. And it might be getting worse progressively, or it may not. It could be associated with weight loss and hematemesis. So that's not surprising. Someone who's not able to take food down, of course, will lose weight. It may be associated with heartburn, gastroesophageal reflux disease, regurgitation, anemia, and respiratory symptoms. Note this. If the problem is with both solids and liquids from onset, then we are likely dealing with motility disorder of esophagus. And the best example here is achalasia. Achalasia is the failure of lower esophageal sphincter to relax. Okay? And you could see, I colored it right here. So achalasia is failure to relax. Relaxation of what? Of lower esophageal sphincter. Then what will happen? the esophageal content will not get down to the stomach, and then they'll be back up. So let me quickly delve into achalasia because we will need this terminology. 25 to 60 years old will likely have it, but it can be at any age. Male to female ratio is equal, but there's one good news here: it is uncommon or is rare. We don't have any known etiology. There will be laws of normal peristalsis in distal esophagus, that is, the junction between the esophagus and stomach. So, here we'll be dealing with lower esophageal sphincter failure to relax, and the content of the esophagus is not getting down to the stomach. In an achalasia, there will be progressive dysfunction from solids to liquids, but over a long period of time, usually years. Regurgitation or vomiting of the undigested food particle can lead to pneumonia, specifically aspiration pneumonitis or respiratory distress syndrome, associated with chest pain, heartburn, difficulty belching, and over a long period of time, there's likelihood of esophageal cancer. Needless to say that the affected individual will become malnourished because the food is not getting down and no absorption because there's incomplete digestion, right? Then they will lose weight. How to make diagnosis of achalasia? We can have upper endoscopy done, but the best diagnostic tool is manometry. That's the best way to diagnose achalasia. Barium swallow could be done with X-ray that will be showing a beak-like narrowing of the esophagus or bed beak. There will be poor emptying of the barium, and of course aperistasis, that is absence of peristalsis. Aperistasis, absence of peristalsis. Other problem is if we are dealing with dysphagia associated with only solids. That may be happening in the phase of stricture. If it is a progressive or intermittent type, it could be peptic ulcer disease as the causative problem, or cancer, or achalasia. But we can make that distinction quickly. If the history is indicating that the stricture is more slowly, then that is pointing to peptic ulcer disease as the cause. But if the degree of dysphagia is more rapid, that might be pointing to cancer. When it is intermittent, we might be dealing with lower esophageal ring or web, or achalasia, or distal esophageal spasm. What are the other possible causes of esophageal dysphagia? Tumors, caustic esophagitis or stricture, peptic ulcer disease stricture, esophagitis from infections, pills or eosinophil, or surgery to the larynx, esophagus, or surgery to gastric region. Radiation side effects, rings or webs, or lymphocytic esophagitis. Motility disorders that might be dealing with here could be achalasia, Chagas disease, primary or secondary motility disorders. Okay, now extrinsic or para-esophageal, meaning the problem is not within the tube, or better put as not within the esophagus itself. Okay, the problem could be with the lung, with the lymph nodes, with the heart, and of course with the vertebral column. Let me explain. There is that probability of a mediastinal mass, either dealing with liver adenopathy or lung cancer. Okay, now compressing the esophagus, and the individual is having swallowing difficulty. It could be within the heart, or before you even get to the heart chamber itself, it could be along the biggest artery ever, the aorta. And in that case, when there is massive aneurysm with enlarged aorta, giving us dysphagia aortica. Don't worry, I'll go into details of that later on. That could be the problem. Okay? And left atrial enlargement can cause dysphagia. You can ask me, how that? Okay. If the content of the lungs, the oxygenated blood, that is expected to empty into the left atrium is completely empty into the left ventricle, we don't have problem. You agree, right? Okay. But when the content of the lungs is empty into the left atrium, the oxygenated blood into the left atrium, and there is mitral valve stenosis with mitral regurgitation, then the backflow will lead to enlargement of the left atrium. Okay? Also in the phase of atrial fibrillation, because when left atrium is filled, it is expected that it should pump and empty into the left ventricle. The same thing is expected on the right side. The right atrium to empty into the right ventricle. But in the phase of atrial fibrillation, instead of full force to push the content of the atria to the respective ventricles, we are not going to find that. It will just be quivering, stasis, and then accumulation of the blood in the respective atria. So, giving us the enlargement of the respective atrium. That is the reason why atrial fibrillation affecting the left atrium will not let left ventricle get complete volume, and then there will be stasis, and then there will be enlargement of the left atrium, and that will compress the esophagus. It could be as a result of left ventricular hypertrophy or secondary to long-standing hypertension. In fact, people with long-standing hypertension having dysphagia, we should have EKG done to rule out, left ventricular hypertrophy and so on before, doing other investigations. Also, if the problem is not within the mediastinum, it's not related to the heart, it's not related to the aorta, it's not related to the lungs, not related to liver adenopathy, we could check one more thing. And what is that? The vertebral column. And this time around, it will be limited to the cervical region, the neck. Osteophytes along the cervical vertebra could compress the esophagus, giving us the swallowing difficulty. So with that, we could see that This man presenting with swallowing difficulty today, or this woman presenting with swallowing difficulty today, might not even have any problem along the throat or the esophagus per se. The problem might be with adjacent structures. So, complete history, complete physical examination, complete investigation will lead to definitive diagnosis, and of course, problem is halfway solved. Okay, if it's none of all these jargon that I've been saying before now, it could be functional dysphagia. And someone is asking me, how do you mean? Don't worry, I'll tell you more in a bit. Okay, what are the possible differential diagnoses? If the difficulty in swallowing is to solids only, let me explain. The patient is complaining that I find it difficult to swallow solids like bread, like rice, like taco, like name it. But I'm fine, drinking water, taking coffee or juice. But when I chew, I can't take it down. And it's getting worse with time. Okay, what could be responsible? It could be esophageal stricture. Could be peptic stricture secondary to peptic ulcer disease, esophagitis, or gastroesophageal reflux disease. So patient with GERD should watch it. Later in life, they can come down with dysphagia, difficulty swallowing. Could be as a result of systemic sclerosis or Zollinger-Ellison syndrome, which is a situation where we'll be dealing with gastrinomas in duodenum and pancreas, causing excess gas stream. And the excess gas stream will lead to too much acid production, and we'll be having peptic ulcer disease. So patients with peptic ulcer disease can come down later in life with dysphagia. Or iatrogenic. The nurses, the doctors are trying to help this patient, then they needed to pass nasogastric tube, but unfortunately, that has traumatized the throat, the esophagus. Or achalasia treatment. While trying to help relieve certain problems sometimes, we inadvertently do cause some others. So achalasia treatment by having mechanical dilation using bougie could be the culprit. Okay, the problem is dysphagia to solids only before, but now I can't take both solids and liquids. Let me explain. The patient comes in and tells me, oh, 3 years ago it was initially to solids. I could drink my coffee, I could drink my water, I could drink my juice. Now, I can't even chew anything and get it down, and I can't even drink any coffee, water, or juice anymore. Then, the first thing I'll be suspecting is query cancer. We'll have endoscopy done about time. If it's pointed to that, we'll have fine needle aspiration for cytology if I'm suspecting cancer. Okay, if the problem is about solid foods only, but the symptom is intermittent, is once in a while, I will have the difficulty, later on I'll be fine, then think of eosinophilic esophagitis, think of esophageal ring, esophageal web, or vascular anomaly. It is intermittent for solids only, esophageal webs or rings, or esophageal rings associated with iron deficiency or plumavation or Parkinson. So you check for pallor or chelonicia. So anyone with problem of swallowing or dysphagia to solids and is intermittent, at the point the food will go down, another time it won't, but liquids will go freely, rule out iron deficiency. Okay, can you believe this? That cardiovascular system could be responsible, apart from the example I've given earlier, talking about left atrial enlargement. Now, here's another one. Though it is rare, but it is possible. And why that? Because vascular anomalies can cause dysphagia by compressing esophagus. How do you mean? Someone has just asked. Okay, large aneurysm of the thoracic aorta could compress the esophagus. And that has its own name. We call it dysphagia aortica. Dysphagia aortica. You could see that now painted it right here. Or severe atherosclerosis. I've said this before. The patient is having difficulty swallowing. Might not be within the throat alone. No. Hello? Get it right. Dysphagia to liquid only. I can't drink my coffee. I can't drink my water. I can't take my juice. But when I chew bread or rice, I'm fine. Then think of esophageal motility disorder, like Achalasia, or distal esophageal spasm, or upper contractile esophagus, or functional dysphagia. Also, it is intermittent and non-progressive. It's not getting worse with time, okay? Then think of distal esophageal spasm or upper contractile esophagus, that is jackhammer esophagus. Then, if you have your barium swallow test done, you can have rosary bead or corkscrew esophagus. Sure. Okay. It might be as a result of gastric outlet obstruction or esophagogastric junction outflow obstruction. The junction between the esophagus and the stomach is lower esophageal sphincter, right? In this case, could be continuous or intermittent dysphagia for both solids and liquids. Could be as a result of scleroderma. It could be secondary to medication-induced esophagitis. How about that? You are on medication that could get lodged in the esophagus, particularly when you take the medication close to the time you go to bed, that is the hour of sleep, and you take medication without enough water. Then pills, those medication could give you esophagitis, later on leading to swallowing difficulty. The symptoms here will be painful swallowing with swallowing difficulty, Odynophagia, dysphagia. Then there'll be pain at the back of your chest that reaches through sternal chest pain. Other situations are Sjogren syndrome or lymphocytic esophagitis. Okay, functional dysphagia. This is an intermittent or after each meal problem. As a matter of fact, there is a separate criteria for the diagnosis of functional dysphagia. Roman 4 criteria will say that there's sense of food, solid and liquid, lodging or sticking or passing abnormally through the esophagus. There will be no evidence of any structural anomaly, no history and no diagnosis of gastroesophageal reflux disease, no history, no diagnosis of peptic ulcer disease, no history or diagnosis of esophagitis, nothing close to motility disorder. You've done everything. You're not getting anything. And this patient is still complaining. All the above would have occurred for at least 3 months, and the entire symptoms would have lasted for 6 months. Then we can make the diagnosis of FD. FD is not fetal death. It's not fibrin degradation product. It is functional dysphagia. Yeah. Okay, functional dysphagia treatment. Reassure. You know why? You've done everything. You are not finding any organic cause or causes. Then lifestyle changes. Advise patient chew the food. Chew the food particles very well before swallowing, and don't rush. You can give calcium channel blockers to relax the smooth muscle, or you can use tetracyclic antidepressant. But be careful. The side effects of tetracyclic antidepressant might be very horrible. You can have mechanical dilation done using Buji. Accurate diagnosis will unlock the difficulty associated with dysphagia. So, for example, it might be Zenker's diverticulum. No, that is pharyngeal esophageal diverticulum. With the help of endoscopy, we'll be able to find that there's a small pouch above the esophagus that will be serving as storing space for food particles, right? And that alone could be traced through the history because there'll be bad breath, gargling sounds, swallowing difficulties, coughing, and repeated throat clearing. So with the history, we'll be able to get that, and with endoscopy, we'll be able to make that definitive diagnosis. Just give it an example. So you can embark on barium swallow with X-ray, endoscopy, esophageal manometry, CT, and MRI. And when accurate diagnosis is made, the journey is halfway through. Why that? Accurate diagnosis will help us with the appropriate treatment. For example, it could be smooth muscle relaxant that will be necessary in esophageal spasm. Some will use Botox, all right? And you can embark on the use of corticosteroid if it is esophagitis, and antacids when it is GERD or peptic ulcer disease. You may just have the need to adjust the diet when you are dealing with esophagitis and some other related conditions. Surgery might be the required treatment in stricture and cancer. And then some will actually need feeding tube to be put in place in severe dysphagia. So accurate diagnosis cannot be overemphasized. Okay, how do we make diagnosis of functional dysphagia? Thorough history. The history should include the onset of the problem, the cause of it, whether it's getting bad or not, and of course for how long, the duration. It would be nice if you can ask the patient to use one finger to point at where the food particle stops. That will let you know whether you are dealing with oropharyngeal or esophageal. Any pain, that is Odynophagia. Is this global hystericus altogether, not even swallowing difficulty per se? Need to find out. Any voice changes before now? And since the onset of this problem, weight changes in the life of this man or woman, any lumps anywhere pointing to cancer, any history of gastroesophageal reflux disease in the past or peptic ulcer disease, any caustic agent ingested before parasite or whatever here, any medication a long time, particularly you take the medication close to the time you go to bed and you drink little water, I need to find out. Still on the history, any history of radiation, any thyroid enlargement recently, goiter, past surgery affecting the head and neck region, stroke, Parkinson disease, amyotrophy lateral sclerosis or multiple sclerosis, any trauma, particularly to the chest and neck region, any cancer that you know of already been diagnosed, even lung cancer, any respiratory problems in this individual. Still on the history of autoimmune diseases, Sjögren's syndrome, scleroderma. Swelling joints will be pointing to scleroderma, of course, with skin thickness and skin tightness. Any chest pain, HIV/AIDS diagnosed already. And of course, cardiovascular problems. Remember, I've said left atrial enlargement, left ventricular hypertrophy, mitral valve stenosis, and of course, dysphagia aortica. Okay, we'll ask all this history around that. And of course, social history, smoking, work, nature, and so on. Okay, physical examination. We need to have the general appearance of the affected individual. Physical appearance related to thyroid gland, exophthalmos, lid-like retraction, tremor, and so on. Stroke physical appearance, that, upper motor neuron lesion, neck for lymph node, and of course thyroid examination, hand for thyroid, palmar erythema, tremor and sweating and so on. We need to have abdomen fully examined from inspection, then auscultation before percussion and palpation. Neuro examination should include vagus nerve, that is cranial nerve 7. Should include glossopharyngeal nerve, that is cranial nerve 9, jointly done with vagus nerve, that is cranial nerve 10. So we have 3 cranial nerves examined here. And of course, we'll auscultate the chest. Okay, the diagnosis will start with barium swallow. If there is stricture, we will know through that. Then, depending on what we could be, we'll move ahead with upper endoscopy. If there are features of malignancy, we can have biopsy with fine needle aspiration for cytology. Then, we are highly suspicious of cancer at that stage. Esophageal manometry will be the diagnostic system of choice when it comes to achalasia. And of course, magnetic resonance imaging, CT or ultrasound could be done. Now, EKG will be welcome here. Somebody is saying, what's the business with EKG? Remember, I've just told you, you could have left atrial enlargement, left ventricular hypertrophy, or atrial fibrillation. And of course, you head to lab. And someone is saying, what's the business with laboratory when we're dealing with dysphagia? Yes, I have a business there. The other time we talk about thyroid gland involvement, right? Let's have thyroid function test down. Let's have gastric pH down. Remember, I have told you that it's likely we may be dealing with Zollinger-Ellison syndrome, with gastrinomas leading to excess gastrin, which will lead to excess hydrochloric acid production. Why not having gastric pH though? Complete blood count with differentials. Somebody is saying, what's the business? But we just talked about eosinophilic esophagitis. Let's see what the granulocytes are saying. And we'll know the value of eosinophil, right? Glucose, amylase, lipids. Any problem with gastrointestinal tract with pancreas? Let's know. Okay, upper endoscopy. With upper endoscopy, we will likely pick ring web stricture or diverticulum. We may also be able to pick erosive esophagitis. And if there's any tumor, with upper endoscopy, we can have biopsy with fine needle aspiration for cytology. And with upper endoscopy, we might be able to see infectious esophagitis. Eosinophilic esophagitis is possible to be diagnosed with upper endoscopy. And of course, with complete blood count, white blood cells, and differentials. Okay, if upper endoscopy is done, the result is bad. It is normal. And dysphagia here is to solid only. Then we'll do something else. Go and have esophageal manometry done. We may have the following outcomes. It could be normal, and in that case, we will diagnose functional dysphagia. But before labeling the individual as having functional dysphagia, please rule out gastroesophageal reflux disease. Number 2, the result of esophageal manometry can come back giving us manometry with equivocal result. So you are not sure to go right or left. Or another outcome could be that we might actually find out that we are dealing with primary esophageal motility disorder. Or the final outcome could be that we are dealing with secondary esophageal motility disorder, for example, systemic sclerosis or diabetes mellitus. So we can do manometry if dysphagia is to solids and liquids with a subsequent motility disorder. Prevention, they say, is cheaper than cure. So in this case, the reason why I brought this out is not to clear per se all causes of dysphagia, no, but at least the affected person will be able to enjoy his or her life for a longer period of time. That is why I'm making this, this particular segment, prevention. So eat slowly, and you can eat very small quantity more frequently, okay? So chew very well before swallowing. And then you can do one more thing, blend your hard food particles before swallowing. Then you will help yourself a great deal if you will walk to your physician, launch your complaint on time, and the definitive diagnosis is embarked upon on time and that is made, then it could be addressed early, in the trouble. Let there be adequate attention to risk factors. I'm not saying the attention that will be given to risk factors will actually cure the risk factors, but since we'll be aware that anyone with stroke may come down with swallowing difficulty, then we will, from the onset, be helping the affected individual on how to go about it. The same with Parkinson's disease, multiple sclerosis. And why have I said this about these three conditions? We cannot improve something that cannot be improved. because with time, some of these conditions will actually, degenerate the more, like myasthenia gravis and all of them. Okay, burns. Let's treat appropriately. Gastroesophageal reflux disease. You can lose weight. You can, give antacids. You can do so many things. Aging. I'm not saying once you are aging, then you must have swallowing difficulty. No, but there are certain conditions associated with old age, degenerative diseases, autoimmune diseases, scleroderma, and the list goes on. With that, you'll be able to say, okay, this is my grandpa or grandma at 95, or then the way he or she will be eating and the particles to be eaten and so on will all be monitored. Okay, cancer. Well, I'm not saying it will cure cancer even when we pay attention, but if cancer signs and symptoms are picked early and then the cancer is addressed early, who knows? You might be at the stage that the chemo or radiotherapy will be able to salvage, okay, or even surgery, and so on, okay, until it has gotten to a state that nothing can help anymore. The same, radiotherapy. What am I talking about prevention and radiotherapy? We just need to tell the patient who will be taking the radiotherapy that you may have swallowing difficulty. So the individual would have embarked on all this from onset. Now, complications. When someone is finding it difficult to take in liquid, of course, they'll become dehydrated. And there may be weight loss. The weight loss from not being able to take down the food particles or from cancer, right? Of course, malnutrition. The reason why I didn't put weight loss and malnutrition together is that some people will become malnourished but not losing weight yet. Okay, so choking may happen. Yeah, if that is the case, it will affect the respiratory system, right? There may be regurgitation with aspiration pneumonia and aspiration pneumonitis. I have several presentations on aspiration pneumonia and another one on aspiration pneumonitis. If choking is not treated on time, if no one is around to help, that may lead to death. Treatment. Functional. In functional dysphagia, let's reverse it. Okay? Stop any non-offending medications. Treat peptic ulcer disease or gastroesophageal reflux disease. Then, please quickly refer. Grab your note, send a referral as it may be appropriate to either oncologist based on your outcome from the diagnostic procedures done, from the history, from physical examination, referral to oncologist, or to cardiologist, or ENT, or endocrinologist, or any other specialty as the case might be. Okay, because dysphagia could be a medical problem and could be a surgical problem, depending on the history, physical examination, the outcome of investigations done. And with that, I've come to the end of this long presentation. I hope this will go a long way to help someone somewhere. And now that you have been fully informed, you could be helpful to someone somewhere someday. Thanks for listening. Remember to subscribe. Remember to share. I appreciate it.